So, applied anatomy and histology, if we see about the esophagus. Esophagus bridges three anatomical compartments: neck, thorax, and abdomen. And the esophagus extends from the cricopharyngeus muscle at the level of cricoid cartilage of the G junction to the G junction, and the border of cervical esophagus span from the cricopharyngeus to the thoracic inlet, approximately 18 cm from the incisor. And the remainder of the esophagus is commonly divided into thirds, with the upper third extending from the thoracic inlet to the carina, approximately 24 cm from the incisor. The middle third extending from the carina to the inferior pulmonary vein, 32 cm from the incisor, and the distal esophagus traversing the remaining distance into the abdomen to the G junction, 40 cm from the incisor. The squamous cell carcinoma of the esophagus is predominantly histology in cervical esophagus and upper and middle third above the inferior pulmonary vein of the thoracic esophagus, whereas the adenocarcinoma predominate in the distal esophagus. Adenocarcinoma of the G junction present a unique challenge because appropriate management of these tumors, either esophageal or gastric, that remains a controversial. And Sievert et al. Offered a classification system based on demographic histopathologic variables, pattern of lymphatic spread, that provides clarity as well. It has been generally accepted worldwide, and this classification scheme: type 1 with considered adenocarcinoma of the distal esophagus, type 2 and 3 they are considered as a gastric cancer, that is cardia and subcardia. So type 1 is distal esophageal, type 2 and 3 are cardia and subcardia. This classification system allowed for a tailored and consistent surgical approach to these tumors, as well as consistency in the reporting outcomes results associated with therapeutic intervention. And it should be noted that in most recent guidelines established by AJCC, G junction tumors with epicenter less than 2 cm into proximal stomach, that is Sievert type 1 and 2, are included under esophageal gastric cancer. So G junction tumor with epicenter less than 2 cm into the proximal stomach, Sievert type 1 and 2, they are included under esophageal cancer staging system. This is according to the new AJCC. And the pattern of lymphatic drainage of the esophageal in surgical approach based on the tumor location in the esophagus. Tumor of the cervical and upper third esophagus drain into the cervical and superior mediastinal lymph node. Tumors of the middle third of the esophagus drain both cephalad and caudal lymph node at risk in the paratracheal, hilar, subcarinal, periesophageal, pericardial. And lesion in the distal esophagus primarily drain to nodes in the lower mediastinum and the cervical axis. Because of the extensive lymphatic network within the wall of the esophagus, skip metastasis of the upper third of the lesion have been noted in the celiac axis nodal basin. Likewise, cervical lymph node metastases have been identified in patients with the distal esophageal. So there is skip metastasis. Some surgeons recommend a more radical lymph node clearing procedure and block combined transthoracic and abdominal approach for lesion of the middle and distal third, and recommend 3 field lymph node dissection: cervical, mediastinal, abdominal, for all the tumors in the middle through distal esophagus. However, lymph node metastases are initially limited in an overwhelming majority of the patients to regional lymph nodes. Lymph node involvement in the lymphatic basin distant from the primary tumor are rarely identified unless metastasis to the regional lymph node have already occurred. So this is Sievert type 1, 2 and 3. Type 1, that is distal esophageal, Type 2 is cardia. Distal esophagus type 1, type 2 cardia, type 3 is subcardia. And this is from 15 to 18 centimeter, it is cervical esophagus. From 18 to 24 is upper thoracic. For 24 to 32 is mid thoracic, and 32 to 40 at J junction is lower thoracic.